Okay, I think we're good here live on YouTube, and we are officially going to get started with the Pink Ribbon Talks 2021. So I want to welcome you. My name is Julie Lanford, and I am the Wellness Director at Cancer Services. And I'm here with Lindy Milligan, who is our Survivorship Coordinator. And we are officially kicking off the 20th Annual Pink Ribbon Talks. And this is actually the second one delivered virtually. We, are adjusting to a different time, but we do enjoy being able to host this virtually. So hopefully you're comfy at home. Now, let's see. We are going to get started, but what we will do is, for those of you who are on earlier, we are doing a game, and on our game we have a scavenger hunt. So we want to go ahead and get moving onto our panel so that we stay on time. So we're going to give out our prizes from the scavenger hunt towards the end. Okay, we've got prizes, so don't log off. That's what I'm going to say. We have a Mary Kay gift basket for people who are winners. Anything else I'm missing, Lindy, on that?
Nope, you're all good.
Nope. Okay, so I do want to introduce our Pink Ribbon Talks Planning Committee. So any committee members, if you will turn on your video so that people can see. Now, we've had quite an enjoyable time chit-chatting. So you've seen their faces, but I'm going to go ahead and introduce them, and they'll wave so that you know their faces. Lindy Milligan, I already introduced, as our Survivorship Coordinator. She's the director of this whole event. So thank you, Lindy. She works here at Cancer Services. Then we have Kathy Bowman, who is Novant Health Cancer Institute Breast Nurse Navigator. We have Jamie Calcutt Flaherty, who is also at Novant Health, and I'm giving names alphabetically, but it's funny how they stack up for similar centers. Okay, then we have Teresa Willard, who is also at Novant Health. Tiffany Morrison Brooks, who is a Cancer Services patient advocate, who is located at Atrium, Wake Forest Baptist. We have Liz Outlaw, who is a breast nurse navigator at Atrium. And Tori Ball is a Novant Cancer Institute nurse navigator. Did I cover everybody? Awesome. Thank you all committee members, because this is always more fun to do as a group. And we appreciate the support of both centers in helping to make this happen, especially as we hear from our expert speakers. And before I turn it over to our first panel, I want to thank a Legacy Federal Credit Union for the continued support to make this program possible. And thanks to everyone who provided goodies for our goodie bags. For those of you who did pick up your bags, I think it's an awesome kit this year, especially I think word started to get around about the umbrellas. So Hanes Brands also helped in donating for the pink shirts. So that's what we've got. I do want to go ahead and transition over to our medical panel, which is a lot of what people want to hear today is what are the updates? What things should I know? How can I make sure that I'm taking the best care of myself? So we are going to move over to our medical panel. We are honored to have the support of both wonderful cancer centers in our area. These physicians have volunteered their time on a Saturday to share their expertise. So each of our speakers is going to take a few minutes, and we hope to have time for questions. So as they're going through, you can feel free to submit your questions in the Q&A box at the bottom of your screen. I would tell you that that's the best place to put them. You can also put them in the chat if you can't find the Q&A box, and we'll try to keep an eye on both of them. We are on a tight schedule, so time may not allow us to get to all of the questions, but we will do our best. All of our speakers' bios are in your program booklet, which was provided to you in your goodie bag and also is available to download online. And so we want to just go ahead and get straight to the great information that our panelists are going to share with us today. So first up, we are going to introduce Dr. Patty Zacon as our medical panel moderator extraordinaire. Dr. Zakon has been to basically all of the pink ribbon talks except for one. So she is very loyal and very used to this conference. So thank you, Dr. Zakon, for joining us today. I am going to turn off my video, but I will go ahead and start sharing our slides for the day. This is our theme, which is what is our next normal. So, oh, the stage is yours.
Okay, so first I would like to welcome everyone to Pink Ribbon Talks, which, as Julie just pointed out, is one of the premier events for our community and what we do for support of breast cancer awareness. So who knew, who ever dreamed that we would be having our second Pink Ribbon Talks in a virtual format? Fortunately, the planning committee who put this thing together last summer recognized that there may be a possibility of a second wave or a fourth wave or fifth wave, whatever wave it was of the pandemic. We had hoped last summer that this would be able to be done live, but they prepared for the contingency that it may not. And fortunately, you know, they had this format already worked out that it could be done virtually. But I want to say that that is not meant to be our next normal. Our next normal is not doing Pink Ribbon Talks virtually. Our next normal is being prepared for whatever hits us. So I would like to first say that we're all growing weary of COVID. It's simply not fair to have to deal with the inconveniences, politics, personalities, and fears related to COVID while still having to deal with the more personal challenges related to the diagnosis of breast cancer. As if you didn't have enough decisions to make related to breast cancer care, now you've got to make decisions about how to protect yourself and your family from COVID, incorporating your own personal beliefs about vaccination, transmission, masking mandates, government control, etc. Decisions, there's simply too much. Next slide. In the breast cancer world, we have long believed in what we call shared decision-making. It's a model where professional experts educate the patient about their diagnosis and about treatment options, and together share in the decision-making based on data, taking into account individual characteristics and preferences. We've got to do the same thing in dealing with COVID. Next slide. COVID has impacted all phases of breast cancer care, from screening to fear of picking up the virus from coming into medical facilities for diagnosis and treatment. We're together learning to navigate the system. We're learning to maintain safe opportunities for screening mammograms without postponing our mammograms because we're afraid of picking up COVID. Together, we're learning how to choose timely and appropriate surgery in spite of fear of COVID. We're not delaying surgery or choosing the wrong surgery because we're afraid. And together, we're learning to navigate the world of providing chemotherapy and radiation treatments safely while really being aware of everything that COVID can potentially do to impact our safety during those treatments. Next slide. The next normal is having responsibility, taking responsibility for our safety. We cannot and should not make decisions out of fear. So what are we responsible for? We're responsible for decisions about vaccination, masking, and social distancing. We're not a product of circumstances. We're a product of our decisions. Next slide. The Delta variant has raised the bar. It's changed everything because it is so highly effective at being contagious. Next slide. We've got to learn something about herd immunity. Herd immunity is really the only way we're going to make this virus go away. The only way we can obtain herd immunity is either through getting sick and developing natural immunity in the process, or aiding the development of immunity with the vaccine. And having witnessed both methods, the medical community very sincerely sees that the vaccination process provides the safer and more effective and more rapid way of achieving herd immunity. so that the virus will not have a host with which to survive and propagate. Next slide. Some people fear the safety and potential complications of a vaccine that was developed so quickly, but the medical community who shares these concerns has perspective, and it's the perspective of seeing the absolutely devastating effects of an unchecked virus in a pandemic. And it's because we have this big picture of imminent death and long-term consequences that prompts us to be so adamant in recommending the vaccine for eligible candidates. We respect every belief and opinion, but also see that individual decisions affect others as well as their health and safety. Next slide. So right now we're at the phase of immunization where we're talking about third doses for some and boosters for other. This is still a moving target, an evolving topic, but we do know that the third dose is available for those who had previously been vaccinated twice with either the Pfizer or the Moderna product. And these are anyone who's over the age of 12, and this third dose is given 4 weeks after the second dose or longer. It's given to the immunocompromised patients, specifically those on chemotherapy, not those on anti-estrogen therapy or radiation therapy, unless they fall into another one of the categories, such as those who've had a transplant or those who have other immunosuppressive illnesses, such as autoimmune disease or chronic kidney disease. In addition to now having the third dose available for Pfizer and Moderna, we also have boosters available. We're awaiting further recommendations from the FDA and CDC, but as of today's date, we have these available for anyone who was previously vaccinated with the Pfizer product. And the booster, unlike the third dose, is given 6 months after the second dose. Right now, it's available for those who are 65 years of age and over, and all residents of nursing homes. It's available for a very vague kind of category called individuals at high risk of severe illness with COVID, such as those with obesity, diabetes, high blood pressure, chronic kidney disease. It's also available for those who work in the setting of high risk of exposure, such as healthcare professionals, teachers, grocery store workers, people who live and work in shelters or prisons. This booster is available on personal honor. No one requires that you prove that you qualify. The one proof that is required, though, is your vaccination card so that the dates can be verified. I'll also put in a plug here for the flu shot. We are anticipating a terrible flu season this year. And that's because last year we didn't see much of it. And we know that in general, only half of the population gets vaccinated for the flu. And in general, the flu vaccine is not quite as effective as the COVID vaccine. So we rely on herd immunity to help prevent the flu season from being terrible. And because there will be no herd immunity, we are going to really have to rely heavily on the flu vaccine this year. And you can safely get the flu shot at the same time you get your COVID vaccine. So next slide. What is the next normal? I think the next normal is just recognizing that each and every one of us has to have responsibility. We have to have responsibility without fear. And that's responsibility for COVID as much as it is for care of our breast cancer. So next, we have a panel of wonderful speakers. These are the breast cancer experts of our community in breast imaging and medical oncology and plastic and reconstructive surgery, and in the ever expanding field of genetics. So next up is Dr. Kelly Cronin, who is the medical director and section chief of breast imaging at Atrium Health, Wake Forest Baptist Hospital. So I'll turn it over to you, Kelly.
Good morning. Thank you so much for having me. This is my first Pink Ribbon Talk, and I'm so excited to be here. I'm sad we're virtual, but I'm so happy we figure out a way to have it done. So I'm going to talk to you about some recent advances in breast imaging. And if we go to our next slide, I'm going to focus on why breast cancer screening is important to everybody. I'm going to talk about some current screening recommendations and what your screening options are. This is not an exhaustive list, but I wanted to focus mostly on mammography today. There are other things, but because we have some current advances, I wanted to kind of focus on those. And when we have some take-home points, you'll see those highlighted with a little pink ribbon this morning. But first, to start with a little bit of history, we are about 100 years in. Breast cancer screening saves lives. We're going to talk a little about that. But if we go to our next slide, we're about 100 years into the idea of mammography, which is an X-ray of the breast, and we have come a long way. But we've known for a long time that we can't, if we want to catch breast cancer early, we can't just do it by physical exam, by looking at the breast, or doing by palpating or feeling our breast. Next slide. And our first major screening study was done in the 70s, and it was this huge study looking at a bunch of women who were offered screening mammograms or not. And this is the first study that showed a significant decrease in mortality, about 30% to women who were getting screening mammograms versus those who weren't. And if you look at this image, I always think it's really striking because it's really hard to see anything in this mammogram. And if we go to our next slide, you can see what our mammograms look like now. So in about 50 years, we have really made a lot of advances in our quality of the mammograms that we can do. So sadly, we know in about 1 of 8 women are going to be diagnosed with breast cancer in their lifetime, and it's the second most common cause of death. And again, the most important thing is getting your annual screening mammogram, because that will reduce your risk of dying for breast cancer. Next slide. And I like this slide too, because this talks about the cancer death rates for women in the US. And if you look at us here on this pink line, we can see that in about 1990, we get this nice slow decline in rates of death from patients with breast cancer. You can also see this, the blue line, if you look at that, those are in other areas where we do routine screening, which is colonoscopies. But in 1990, we launched massive screening programs for women in the US, and we can see that has resulted in a 38% decrease in your chance of dying from breast cancer. So we know that getting your annual screening mammogram in this early detection is the best way to decrease your chance of dying from breast cancer. So what is screening recommendations right now? They can be a little confusing. There are a lot of different recommendations, but Society of Breast Imaging, American College of Radiology, and the American Society of Breast Surgeons all have the same recommendation. And these are your experts in breast cancer imaging. We believe that screening at age 40 and getting your screening mammogram every year is the best way to prevent your chance of dying from breast cancer. If you have a family history, which Twee's going to talk about here shortly, we may recommend you actually start screening earlier or with different modalities. We know that if we are doing routine screening mammograms, the size of the cancers that we can see are much smaller than the ones we just detect by physical exam. So again, finding your breast cancers early is the best way to give you the best outcome and the most treatment options. So what is a mammogram? If you haven't had a mammogram, this is what a unit looks like. This is a mammogram machine. Typically, we'll do 2 views of each breast, and there are different types of mammograms. We initially had started with film screen mammogram, but most of our centers now have moved to what's called a digital mammogram. In 2005, this was launched because it worked better for patients with dense breast tissue. And now we are on to 3D tonal synthesis, and you've probably heard of a 3D mammogram. And if we go to our next slide, we'll kind of see what that is. There's our film screen. So you can see the image quality has gotten better if you go to our next modality, which is digital. And our last one here, we'll talk about 3D tonal synthesis. Next slide. Okay, so the idea of 3D tonal synthesis, if you advance that, is that the X-ray tube is going to move in an arc as it serially acquires images. And if you hit the next slide thing, you'll see that little video of what happens. These images are then reconstructed to very thin slices, about 1 millimeter thick. So when the radiologist is looking at your mammogram, we can see through some of the tissue better. Go to our next slide. And there should be a little play button, maybe not, but you can see that this is what we call dense breast tissue. So the breast tissue is more white than the other thing that makes up the breast, which is black. And you can see the 2D image on the left versus the 3D image on the right. You've got that spiculated mass, which stands out and is much easier to see on that tomosynthesis or 3D mammogram. Next slide. So we know tomosynthesis works really well in dense breasts, but it also benefits all patients in all ages. We see more cancers at a smaller size, and we also call less patients back when we look at using 3D mammograms, tomosynthesis versus digital mammograms or just the 2D. But it's really, really important that women who are younger, so the 40 to 49-year-old age group, the 3D really, really works better, and we find smaller cancers again, and we tend to call you back less for normal findings. Next slide. So if you have dense breast tissue, you'll benefit the most from 3D mammograms. And thanks to Dr. Zekin, she just touched on this a little earlier. Is it safe to schedule my mammogram? I wanted to make sure we touched on this because there was just a question in the Winston-Salem Journal about this. It is safe. We do social distancing. We all wear our masks. Our whole team right now, I can say at Atrium is vaccinated. I know Novant has the same initiative, which we think is so important. We want to be able to get you in there. A lot of women have missed since this pandemic. Don't be scared that you've missed. You're not alone, but it's safe to come in. We'll get you in and out quickly for your regular screening mammogram. Next slide. So speaking of COVID, we had a lot of issues come up with the COVID vaccine. And I wanted to kind of touch base on what we're seeing and kind of the timing of getting your screening mammogram and your vaccine. Next slide. So very rarely, about 1% of all of our patients with breast cancer will present with swollen lymph nodes under the arm, which you can see and that this patient had. The funny thing is when patients get a vaccine, and this is any vaccine, it's not unique to COVID-19 vaccines, it's normal to get swollen lymph nodes under that arm where you got the shot. And that's a good sign. It's your body reacting to that vaccine. It means you're getting that protection that you need. But we just want to make sure that this is not an early or a sign of breast cancer. You go to our next slide. It is okay. We used to ask that you delay, but if you already have your mammogram scheduled and you also want to get your vaccine or your booster, it is okay. But the important thing we want you to do is just tell your technologist as to when you had it and in which arm we had it. So if we do see those changes, we won't need to call you back and we won't be alarmed about that. Slide. In this, I wanted to touch base because we're really excited about this. And this is our newest modality, and we are just getting our unit in at the hospital at the Cancer Center at Atrium. And this is the idea of contrast-enhanced mammograms. And it uses iodinated contrast, or what they use for CTs, to look at tumors in the breast. Slide. And this idea of dual energy is not new. If you've had a chest x-ray, they probably did dual energy and you didn't know it, and it helps to track out different things. You can see that this lung cancer is much easier seen on the dual energy where it subtracts out the ribs and you see that soft tissue better. Next slide. And so the idea is the same for the breast tissue, right? So if you look at the images on the bottom left, you'll see that it's able to subtract out this dense breast tissue, and you can see this small cancer that they see in the left breast, kind of there in the lower inner part of the breast. So if you have dense breast tissue, if you're at high risk, it may be very, very helpful for you to have a contrast-enhanced mammogram. Again, it highlights the lesions because it's what's accumulating iodine, but one thing I want to let you know is it's not for routine screening. It's a little higher radiation dose than we typically use for a regular 2D or 3D mammogram. But if you have any questions, just ask your radiologist if this could be the right test for you. So again, dense breast tissue or questionable findings on a regular mammograms are really good. Problem solving too is going to be this contrast enhanced mammogram. You'll be hearing a lot about it as we use it more and more. So ask us if it might be right for you. And that's it. I wanted to just kind of introduce you to our team. This is our breast imaging team here on the left, and these are our kids on the right. You already saw my husband's picture as we were here waiting to talk, but thanks so much for having me, and I'm here to answer any questions if you have any. And I'm going to turn it over to Dr. Crook now.
Thank you, Kelly. That was excellent. I want to first off thank everyone who invited me to speak today. I'm relatively new at Novant. This is my first ever pink ribbon talk, and so I'm just really honored to be asked to be speaking on behalf of my medical oncology colleagues. Next slide. So, Dr. Zakon and I have the benefit of residing in an office across the hall from Dr. Zakon, and she's become a very good friend to me. And when this issue of Pink Ribbon Talks came up, we started batting around different ideas of what I could focus on, because it's a little overwhelming to be asked to talk about an update on breast cancer treatment in 10 minutes. And my mind automatically went to all the new and exciting drugs that have been approved over the last few years. But as Patty and I spoke a little more, we both became convinced that one of the more interesting things to happen in medical oncology over the past couple of decades was actually the idea that less is more. And while it's exciting to talk about new fancy drugs that are developed, I think it's equally as exciting to talk about the ways in which we've been able to identify subsets of women with breast cancer who do very well and who are able to get away with less treatment. I think anyone can mention that, or can appreciate that when patients first come in for their initial consultation visit, their biggest fear is potentially needing chemotherapy. And so to be able to approach some of these women in a knowledgeable fashion and reassure them that they are likely to do well and not need chemotherapy is actually extremely rewarding. And that's something that's changed a lot over these past few years. Interestingly, as Patty and I were having this conversation over the past couple of weeks, this article popped up in the New York Times just this past Monday. So it was really great timing. I would recommend anyone who has access to New York Times to read this article. It's easy to read, it's well written, and it's just really a very nice examination over the past few years, how our approach to treating cancer has changed. The article specifically focuses on breast and lung cancers. And they describe what has happened as a quiet revolution in breast cancer treatment. And I think that's a beautiful statement, not something that's gotten a lot of press or a lot of attention, but certainly something that all of us in the field have, really appreciated. Dr. Lisa Carey, who's one of our big breast oncologists up at UNC, is actually quoted in the article, and she is reflecting over her career and describes the care of the breast cancer patient today as a totally different world from when she started practicing. And, as someone myself who's been doing this for 21 years, I would say that that's an extremely accurate statement. Next slide. So if we think about how this paradigm shift has happened over time, it's interesting to go back to the National Cancer Institute treatment guidelines that were published specifically related to breast cancer back in 1990. And at that time, if you read those guidelines, chemotherapy was recommended, and this is in the post-operative setting for women who have had curative surgery for their breast cancer, for about 95% of all breast cancer patients. And that's really remarkable if you think about that. And that recommendation was made with really good intent, because in that era, we appreciated that when you looked at studies with large groups of women, those that received chemotherapy after surgery had a decreased rate of cancer recurrence, particularly recurrence as metastatic disease. And therefore, if you could prevent metastatic disease, you could save lives. And because we appreciated that that was a benefit, we applied it across the board. And so really that led to almost every single woman, the exception being women with extremely small breast cancers, to be recommended for postoperative chemotherapy. If you can go back, there we go, thank you. When did the change start to happen? Well, in November 2006, the drug Herceptin was FDA approved to use in the postoperative or adjuvant setting for the 25 to 30% of women that have this HER2 protein on the surface of their breast cancer. And this was the first time we were using a non-chemotherapy drug other than endocrine therapy in the postoperative setting. And Herceptin is given with chemo, so it was not eliminating the need for chemotherapy. But what it did was it made us aware that in certain women, chemotherapy had less of an impact on outcome than we had appreciated. If you look at those original Herceptin studies, the risk of recurrent breast cancer was decreased by about half with a course of Herceptin given postoperatively. And while chemotherapy was incorporated in all of these studies, really the type of chemotherapy was much less important than the receipt of the Herceptin. So again, we began to acknowledge that there was a slightly lesser impact from the chemotherapy drug itself. One of the big oncologists in the United States, who's quoted in that the New York Times article I showed you, described this era as scary. And that made me chuckle, but I think it's very accurate, because we were going from a period of time where we were thinking about giving women 2 or 3 chemotherapy drugs, and even thinking about, in some women, maybe as many as 4 chemotherapy drugs post-operatively, to now looking at scaling back and giving less drug and hoping that this would lead to equally good, if not better, outcomes. But over time, as the data began to flow in, the oncologists as a whole began to embrace this idea of de-escalation of treatment. Next slide. And this is an article that, and I don't expect you to be able to read the small type. I put the summary statement over on the right in bold, but this was an article published in the Journal of the National Cancer Institute back in 2018. And I thought it was interesting because this article was done by polling breast cancer patients. They actually polled 5,000 women, about 3,500 responded. They also polled oncologists, presenting them with certain scenarios of breast cancer patient and asking about the use of chemotherapy. And just in this 2-year window, comparing 2013 to 2015, we saw chemotherapy use in early stage disease decline from 26% down to 14%. And even in women with lymph node involvement, we saw chemotherapy use decline from about 80% closer to 65%. And again, think back to what I said earlier, in 1990, the approach being to give chemotherapy, or at least recommend chemotherapy, to 95% of women. You're seeing a dramatic decline in the use of chemotherapy. And before we move on, I just want to emphasize, I don't want anybody to take away from this talk that chemotherapy is not important. I was a little wary as I was preparing this that we would have people walking into their oncology office on Monday saying, well, Dr. Crook said I don't need chemotherapy. There certainly are plenty of scenarios where chemotherapy is still beneficial in the breast cancer treatment and in preventing recurrent disease and death. But what we're talking about here is trying to isolate out those women who can do well without it. And, you know, that's really where our knowledge base has improved. Next slide. So in the current era, how do we decide who these women are? How do we decide in whom we can safely avoid chemotherapy and expect our women to still do well? And we do that primarily today with genomic tumor testing. And my only criticism about the New York Times article is they repeatedly use the term genetic testing, which is completely different. We have a genetic expert here who will speak to you about genetic testing. These studies we run on tumor tissue, we refer to as genomic testing, just so as not to confuse the two. But what this is measuring the expression of different genes within the tumor itself. So again, different from testing your own DNA for mutations, but actually looking at genetic expression within the tumor tissue. And what we have learned is that the expression of these genes can help us predict how the tumor is likely to behave. How likely is it to grow? How likely is it to spread or recur? And there are several different FDA-approved genomic studies for breast cancer. You know, the ins and outs of all of them is certainly beyond the scope of this talk, but I will tell you that here at Novant, for a number of reasons, the one we generally prefer is a study called the Oncotype Dx Test. And so many of you who have come in for breast cancer consultation in the past several years have probably talked about Oncotype testing with your oncologist. The testing is approved for women with early stage disease that is both hormone receptor positive and HER2 negative. What you get are 2 different scores, if you will, or 2 different answers. First, you get a numeric risk of the likelihood of your cancer coming back in other parts of the body. So what we call systemic or distant relapse, what most people refer to as metastasis. So the risk of that happening over the next number of years again, based specifically upon how your cancer is acting. So this is really getting down into the weeds. This isn't necessarily just thinking about the size of the cancer or whether or not lymph nodes are involved, but rather thinking about how your individual tumor DNA is acting. So you get a numeric recurrence risk, and then you get a second statement telling you what the magnitude of benefit from post-operative chemotherapy will be, if any. And again, the rewarding thing for many of us is to see women come back with numbers like for example, 5% risk of their cancer coming back over the next 10 years and less than 1% chemotherapy benefit. And that allows us to, very assuredly, based on good science, tell a woman that she can avoid chemotherapy in the post-operative setting and still move forward with a very high rate of cure. Next slide. Because there is no radiation oncologist speaking as part of this panel, I thought I would throw in some additional information. Genomic testing is not just to answer the chemotherapy question. We use it in other arenas of breast cancer as well. There is a similar type test called the Oncotype Dcis score, and this is for women with non-invasive disease, or DCIS. It, again, analyzes 12 different genes within the tumor. It predicts for the risk of local recurrence. So again, as opposed to talking about risk of coming back in other parts of the body, now we're thinking about what the risk is of the cancer coming back within the breast, either additional DCIS or even invasive disease. And we use this specifically to make thoughtful decisions about the need for post-operative radiation. So whereas the first Oncotype study I presented to you tells us yes or no in terms of benefit from chemo, this is giving us information about likely benefit from post-operative radiation. And again, is helping us recognize that there are a subset of women with non-invasive breast cancer who will do very well and still be able to avoid radiation post-operatively. Next slide. A newer genomic study that most of us are fairly excited about is called the Breast Cancer Index. And as opposed to the two I just presented to you, this one specifically is looking at the role for a protracted endocrine therapy course. So some of you have probably sat in your oncologist's office and had the conversation about 5 years of anti-estrogen therapy versus 10 years of anti-estrogen therapy. And that's a decision that can sometimes be tough. We have some data to tell us who will benefit from 10 as opposed to 5, but it's not very clear cut. There's a lot of ins and outs. Some women struggle with side effects of anti-estrogen therapy. And certainly if we think they're going to do okay, stopping the treatment after 5 years, we want to be able to allow them to do that, while other women will further decrease their risk of recurrent breast cancer with an additional 5 years or 10 total years. And we want to afford them the opportunity to lower their recurrence risk to the greatest degree possible. So what this study, known as the Breast Cancer Index, does is it looks at 11 genes within the tumor, specifically attempting to predict the risk of your breast cancer coming back after 5 years, which is not the same thing as the initial recurrence risk you're predicted at diagnosis. So this is assuming you are at the 5-year mark, you are still cancer-free. What is the likelihood of it coming back in the subsequent years? And will you or will you not likely benefit from years 6 through 10 of anti-estrogen therapy? So this is a study we don't generally order at diagnosis, but we order it or potentially order it when we're getting to the 5-year point of anti-estrogen therapy. And we're looking at things like tolerance and, again, trying to quantify the amount of added benefit you'll get from staying on treatment so that we can be making thoughtful decisions with our patients. Next slide. Lastly, I just wanted to remind everyone all of this information that I've presented and that our other providers will be presenting is all based on good scientific data obtained from clinical trials. And, we really try to be thoughtful and used evidence-based information to give guidance to our patients. And the only way we get that information is by enrolling patients in trials. This is kind of the latest and greatest de-escalation trial that we either have just opened or are about to open here at Novant. And it is called the Comet trial, comparison of operative versus monitoring and endocrine therapy. Again, this is for women with non-invasive breast cancer or DCIS, looking to see if we can eliminate surgery from their treatment program. So again, looking at each aspect of our traditional care and seeing in whom can we afford to eliminate treatment and still have good outcome. And what this trial will do will randomize women into what is called guideline-based care, which will always include surgery, and then may or may not include radiation or endocrine therapy thereafter based upon specific tumor characteristics, versus what we call active surveillance. And it's a thought process or an idea that's a little intimidating to some, but it's a thought process we have applied to other cancers for years, most notably prostate cancer in gentlemen who are followed with just close follow-up. And we know many women with DCIS will not go on to develop more invasive or aggressive breast cancer. And so this thought is trying to eliminate surgery, can include anti-estrogen therapy, and follow women over time and see if we are able to avoid surgery in those that are destined to do well related to their non-invasive disease. Next slide. So I hope I've been able to give you some good information. I don't have a picture of my kid. She's 21. She doesn't like to be added into the end of my presentations any longer, but this is my furry kid, and I'm happy to answer any questions about any of this data I've presented in our Q&A session later. And next, I'll be turning over to Dr. Adam Katz. Dr. Katz is a professor of plastic and reconstructive surgery at Atrium Health, Wake Forest Baptist, and he serves as the director of Plastic Surgery Research Laboratory. And the stage is yours.
Great, thank you very much. Good morning to everyone. And I'm also a first-time participant in the Pink Ribbon Talk, so I'd like to thank you all for welcoming me to be a part of the program. A slight change, I guess, from some of the other talks, and I'm going to use the next 8 minutes or so to try to provide a primer about reconstructive options. Because obviously when we see, next slide, please, when we see patients, next slide, that are interested in reconstruction, they've also just had a diagnosis of breast cancer, and for obvious reasons, they're overwhelmed with decisions and information. So the breast reconstruction options are equally complex at times, and it's a bit overwhelming sometimes at the moment to understand all of the options. One of the first places I start with patients when I see them is to make sure they understand that by federal law, if their insurance is covering the mastectomy, the insurance has to cover their reconstruction of their breasts. And not just that, the insurance also has to cover by law any reconstruction or surgery we might want to do on the non-cancerous breast to achieve a symmetrical result. So some patients aren't aware of this. There are, of course, deductibles and things like that, but it's important that women know that this is an option and a right, essentially, by law. Next slide. If we look at what women choose to do, and from a plastic surgery standpoint, I know I can speak for my colleagues, we understand that some women won't want to have reconstruction, and that's perfectly a fine decision. We're just interested to make sure patients know that it's an option, and for those that are interested, to provide them with information to help them make an informed decision about whether to get reconstruction and what type of reconstruction. Each year, roughly the numbers that I've found suggest that each year out of the women that are diagnosed with breast cancer in the United States, about half of them or so are treated with a mastectomy. And of those patients that get a mastectomy, less than half choose to have breast reconstruction at this point. But of those who choose to get breast reconstruction after mastectomy, almost all of them, nearly 82% of them, get reconstructed using breast implants. Next slide. So the things that go through the mind of a reconstructive surgeon regarding a reconstruction are the following things. Of course, your overall medical health, but specific things related to the cancer type and treatment are things like whether you're going to potentially need chemotherapy before or after surgery, whether you're statistically likely to need radiation, because we usually won't really know whether radiation will be recommended until after the lymph node biopsies at the time of surgery. There are different types of mastectomies that can be performed, and this is very important to us because where the scars or incisions are placed are critical to how we might approach the reconstruction. From patient-centric point of view, as mentioned, besides whether you have diabetes or heart disease and hypertension, weight or body mass index is an important variable in our literature about risk of complications. We're interested in what your current breast size is and what you ideally would like to be size-wise after. It's possible for us to make patients larger than they were before mastectomy or smaller. Any previous surgeries on your breast specifically, such as previous biopsies and scars that might impact the flow of blood to the tissues for healing. And smoking and nicotine is a really big red flag for us. And we ideally like to have patients be free of all nicotine for 30 days before any reconstruction. That's not always possible. And of course, treatment of the cancer takes priority, but in an ideal world, our best results can be achieved when nicotine is out of the system. It's important also from the reconstructive surgery standpoint that we clearly express what a realistic expectation from breast reconstruction is. I tell patients that they will have breasts that will have little to no feeling or sensation because the nerves that are cut from the mastectomy. They will all have some sort of scar on their breast, which is permanent and forever. And so the real goal is to reconstruct breast mounds that are the size that you'd like, a shape that is nice and symmetrical on both sides, and that will look good in clothes or bathing suit, so that if you're out and about, no one would think twice that you've had breast cancer or reconstruction. And it goes without saying that there's an abundance of research that shows that reconstruction really helps with the healing process. Next slide. In very broad general terms, there are two polar opposite ways or distinct ways we can reconstruct breasts. One is with implants, one is with your own tissue, and then every sort of combination that you might think of in between. Next slide. There is no perfect way of reconstructing breast, and it's really individualized for each person based on their risk factors and their body shape and their goals and tolerance for risk. Here is just a small quick table about the pros and cons of each side. Implants tend to be quicker, shorter operations and let patients get back to their life and work much quicker. But because it's a device, just like an artificial hip, it might wear out at some point over the next 10, 20, 30 years. And so you're going to need some touch-ups over time. Whereas if you get reconstructed with your own tissue, it's a lot more involved upfront at the beginning, some higher risks, some more complex surgery. But once you get through that phase, you're going to kind of be good to go for the rest of the time. Next slide. Timing is very important. Everyone wants to have their breast reconstructed right at the time of mastectomy so they can wake up with new breasts, but this is really only possible in a small percentage of patients. Another opportunity and important to know is that any time after mastectomy, months, years later, reconstruction is possible, so the doors are never closed. And a very common approach that's emerging right now is a mix between the two, where we wait a week or two after the mastectomy to begin the reconstructive process. And this has to do with reducing complications that are associated with the skin that is a little bit starved of oxygen and blood supply after the mastectomy. Next slide. Other trends regarding implants is we have saline saltwater filled implants or silicone filled implants. The silicone new generation implants are very good in my opinion. There's no fluid nature to them. They're highly cohesive, like a very thick jam or jelly, almost like a gummy bear. So they don't leak if there's a hole in the shell, and it's very difficult to tell that they don't leak. So MRIs are recommended by the FDA every 3 to 5 years for surveillance. The capsule can be smooth or textured, but now textured implants are completely off the market because they've been associated with a very rare lymphoma called BIA-ALCL. We can talk more about this later, but because it's such a rare thing and now the textured implants are off the market, this will disappear completely. And for those who have textured implants that don't have any symptoms, it is still the recommendation of the FDA and other health authorities that nothing needs to be done at this time regarding your implants. Next slide. We also have decisions about where we can put the implants. It can be below the muscles or on top of the muscles. The general trend now has been to move them on top of the muscles because it's less pain for the patient at surgery. There's less something called animation deformity, which is when the implants can move every time you use your pectoralis or upper body and arm. That's when they're placed under the muscle. It's not a problem per se unless it causes discomfort, which it does in some women. With the on top of the muscle, we can expand the expanders more quickly. We can sometimes do the direct to implant better. And in my opinion, and some other my colleagues, we think ultimately gives a more natural appearance on top of the muscle. Next slide. These are the different tools we use to wrap the implants. And this allows us to keep the position of the implant where we want and to create a shape on the side of the breast that's more pleasing. And we do this by wrapping the implant either with ADM, which is what you see on top there. That stands for acellular dermal matrix. And these are basically tissues taken from human donors that have been treated with chemicals to remove all the cells and act like a sponge for your own tissues to grow into and remodel. We also can use other meshes that will dissolve over time. Next slide. Finally, two more slides. Another trend that is suitable for some women, specifically women with a relatively small tumor with very large breasts. Maybe you've had neck pain and back pain for many years. We treat macromastia or large breasts a lot in our practice. And what we do essentially is coordinate with the surgical oncologist and do a reduction or breast lift, which is called a mastopexy, in combination with removal of the tumor. It provides a nice new shape to the breast, and the radiation tends to not affect the shape over time as much as with a lumpectomy without this. Next slide. And then the last thing I just wanted to touch on is when we do reconstruct breasts with the patient's own tissue, there is a new trend and a lot of interesting research going on as to how we might be able to provide feeling and sensation back to the mastectomy skin or the flap skin. And we're doing this by sewing nerves together under the microscope along with the blood vessels. And this is early research, but I think holds some promise for a downside of mastectomy that we don't talk a lot about, but I suspect is important to many patients. Next slide. Now, I think that's all for now. And if we have time later, I'll be happy to answer any questions. Again, thank you for including me in the program. And I will now turn it over to the last speaker for this panel, Dr. Vu, who's going to speak on genetics.
Good morning, everyone. Thank you so much for having me back. I think this is my second time to participate in the Pink Ribbon Talks. This is a wonderful community, and I'm appreciative to be a part of it. So my name is Thuy Vu, and I'm one of the genetic counselors here at Wake Forest Cancer Center. And so I'm just going to touch base on, genetic testing trends. The theme of today is what is the next normal, but we already have a new normal for genetic testing in hereditary breast cancer. And so I'll touch base on that today. And so, in general, right, we recognize that breast cancer is a very common disease in women. But really, of all the women that are diagnosed with breast cancer, thankfully, we find that only 5 to 10% of these cases are due to an inherited susceptibility. And so, keep that in perspective, right? And I think many patients are very surprised to kind of hear that statistic. But for as common as breast cancer is, majority of families that are impacted by breast cancer, we're not super worried that the family history is due to, like a high risk gene mutation. So 5 to 10% of breast cancers are hereditary. The most common of those are caused by mutations in the BRCA1 and BRCA2 genes. And through, research efforts, collaborations, families and patients participating in all of these research studies, we've identified many more genes that contribute to hereditary breast cancer. And that's what genetic testing focuses on. We also recognize, sorry, back up, Julie. We also recognize that about 15 to 20% of cancers are called familial clustering. And so there's a bit of a nuance to this. So familial clustering of breast cancer is where, we see that there's several women in the family with breast cancer, but these cases are not in successive generations. They're not all premenopausal onset. It's more that the breast cancer risk in these families, they're attributed to multifactorial. So it's not just one big bad gene mutation. It's likely due to a combination of a few low risk genes that kind of add up. So it's kind of like small marbles make a mountain, right? So a lot of these few low risk breast cancer genes, add up, but that's also impacted by personal risk factors. So smoking history, obesity, aging. So in families with familial breast cancer, we definitely do coordinate genetic testing in these families, but in most cases, we're not going to find a mutation in those families. So that can give families a lot of reassurance, right, that it's not due to a high-risk BRCA gene mutation. All right, next slide. So in those families that do have hereditary breast cancer, where it is due to a high penetrant gene, genetic risk, when we ask about family history, we typically hear about women diagnosed with breast cancer like in her 30s and 40s. So that's considered, 2 decades earlier than when most breast cancers typically happen. We have many successive generations of women with breast cancer, and this is where they cluster all on either mom's side of the family or dad's side of the family. So we're kind of seeing that pattern on one specific family lineage. We may see other types of cancers clustering these families as well. So male breast cancer, ovarian cancer, and pancreas cancer. Those are very rare cancers, but we tend to see them often in families that have an inherited risk. And so, in terms of like recognizing whether your family history, is worrisome for a high risk gene mutation, this is where this countdown to genetic testing, this 3-2-1 kind of pattern can be helpful to think about. So if your family has 3 or more relatives, with this pattern of like breast or these other rare types of cancers that cluster all on the same side of your family, I think it would be worthwhile to consider genetic evaluation and discuss genetic testing. If you have 2 close women who've had breast cancer or these other patterns of the rare cancers in the family, particularly if one person was diagnosed under 50, that's another red flag to consider genetic evaluation. If someone's had 2 different cancers, right? A woman who's had bilateral breast cancer, for example, or someone who's had breast cancer and then later she develops ovarian cancer. That's another red flag where we want to look at your family history to kind of look at the big picture to see what's going on. When patients are referred to have a genetic counseling visit, we genetic counselors have the luxury of spending 30 to 60 minutes with patients because we really do a deep dive into the family history. We're going to ask about everyone in your family, all the men, all the women, current ages, how old people live to be on both sides of your family. And then we'll ask about the cancer histories, ages when people were diagnosed, the different types of cancers that are in your family, because we want to see how the cancers fit into the big picture of your family. And so I think for many patients, they keep like a running list of cancers in their family, a running list of people who've had cancers, and then we draw it out and we map it out in a family history. It doesn't look so worrisome, right? So I think just kind of reviewing the family history, making those phone calls, opening up that family Bible or the family record book and really like reviewing the different cancer histories and then putting it down on paper in the context of your entire family tree. I think that process can be very enlightening itself and kind of clarify details that might have been missed or forgotten over the years. But then when we kind of look at the overall family history, then we'll discuss if genetic testing would be helpful for the family to consider. So just by having the risk assessment, it doesn't always mean that you need to have genetic testing, because I think the review of the family history and just reviewing the risk factors that contribute to cancer, I think that's a valuable conversation to have. And then when we do talk about genetic testing, then we kind of dig into like, okay, well, what do results mean for you? What does it mean for your family members? And we kind of do a deep dive, into what the different cancer risks are and how do we manage those cancer risks if your family is found to have a mutation. Next. So when we do talk about genetic testing, it's very helpful to figure out like who is the most important family member to initiate genetic testing. And typically that's the person who's had breast cancer, right? Or these rare types of cancers in the family. Because when a family or when a person has a hereditary gene mutation for cancer risk, it is a 50% chance that you can pass that particular mutation down each time you have a child. So if I test someone who does not have cancer history and she has a negative result, does that mean that her family has a mutation, but she did not inherit that? Or is it because there was no mutation to begin with in the family, right? And even still, there's a third scenario to consider, is that despite all the fancy genetic testing that we have, we're still not able to find mutations that contribute to all of these really high risk families. So we still have a lot of learning and research to really close that gap and try to find a genetic explanation for these families that have very strong family histories. The other part of the risk assessment is that because genetic testing has been around for over 20 years now in hereditary breast cancer, we have lots of patients and families who come in that have already had genetic testing. But because of all the updates that we've had over the years, it's really important to figure out or even try to track down that genetic test report, even if it was a negative result, because we want to figure out how comprehensive that genetic test was at that time, and what additional genetic testing options or even research participation could be offered or considered in these families. And so even though on the technology side and the science side we got to keep up with those changes, the last bullet is that family history continues to change and evolve, right? And so you may have had your initial genetic counseling and testing visit, back in 2005 or 2010 when you're initially diagnosed. Fast forward 10, 15 years later, you are, doing amazing as a cancer survivor, and there may be new cancers in your family that have come up, right? Maybe, there's new genetic testing that looks at the family cancer histories in a different lens, because these new genes may be associated with a different pattern of cancers that we really hadn't recognized that associated pattern, 10 or 15 years ago, that kind of thing. So, if you're listening to this and you're kind of like starting your running log of all the different people in your family who've been impacted by cancer, think about it as far as like, okay, here are the people in mom's family, here are the people in dad's family, and, start that dialogue with your family. I don't know that you're going to be considered prying or, asking, invading people's privacies for this information. I think the perspective should be more that you're all from the same gene pool, right? So your efforts are going to help out your cousins and all of your other family members. So let's really work together as a family to, share this information because, you guys can all benefit from all this information together. All right, next step. So with the genetic testing, if you've had genetic testing in the last, 5 or 8 years, you've probably heard about the word panel testing, or sometimes it's called NGS testing or multi-gene testing. So that really has been around consistently, probably since like 2013, 2015. But panel testing in general has been around. The first panel genetic test came out in 2011. And so I'll take a step back and kind of break that up for you. So BRCA1 and BRCA2 gene testing became available in 1994. So for the longest time, we only had analysis of those 2 genes, and that was it. But we had many families where we were highly concerned they should have some genetic mutation found, because multiple generations, everyone was young, rare cancers, these features were all seen in these families. And so just through these research efforts, these families contributed to efforts where we identified lots of other genes. But these other genes were really expensive and they were really rare. And so most families and most labs didn't offer clinical testing for these other genes. What changed was that in 2011, the physician scientist, Dr. Mary Claire King, she's the one who discovered the BRCA1 gene. So in 2011, she rolled out this panel test where it was a panel of over 30 genes related to hereditary breast cancers. So through all these research papers, she pulled out all these other genes that had been found and put it all in one test. And that's what became available in what we call panel testing. So basically a panel test is where you have one blood draw, one test, one insurance card cost, but we're analyzing multiple genes simultaneously. So we're just much more efficient with our genetic testing efforts now. So that first test was in 2011. Most labs within the next couple of years started offering panel testing. But many of these genes, we didn't have a lot of data on cancer risks and therefore cancer screening recommendations. So it took many more years for us to really learn from these pioneering families, what the cancer risks are. And so the first guidelines for management of these other genes, those really didn't start rolling out until like 2015, around that time. So I would say if you've had genetic testing prior to 2015, greatest likelihood is that it was only BRCA1 and BRCA2. If you've had genetic testing since 2015 to the present time, there's a very high chance that you would have had a panel testing. So the other complication is that not all panel tests are created equal. So you can see here under the bullets, we have STAT panel tests. Those are the BRCA1, BRCA2, and another 4 to 7 genes, other hereditary breast cancer genes. We can test for the full spectrum of breast cancer related genes, which is up to 20 genes. We can test for genes related to both breast and ovarian cancers. So that can be up to 30 genes. And then we have cancer panels that have genes related to pancreas, prostate, colon. And so that can roll up to 40 or even 80 genes. So genetic testing, if you've had a negative result, you always want to track down, when it was done, how many genes were on your test, because think about where we might be in 5 or 10 years from now, right? And so not all panel tests are created equal, and having that report is really important to share with your physicians and with your family members. Next step, our slide. All right. So yeah, so if you've had genetic testing already, you want to keep perspective of like when it was done, because you might be offered updated genetic testing. And so in our breast survivorship clinic, our providers are really great about kind of touching base with our patients and trying to map out that timeline. Like, oh, you were diagnosed in 2005, you had genetic testing right after that. All right, that was a time when it was only BRCA1 and 2 testing. Let's get you back into genetics so we can update your family history and talk about all the new genetic testing options. Yep, thank you. And so, yeah, you want to get a copy of, that negative test report just so we can kind of see what's been done and what needs to be done next. If a family member has had genetic testing and it's positive for a mutation, you definitely want to get a copy of that report, because then that allows moving forward, the labs can do targeted genetic testing for that specific family mutation. So you need to provide that relative's positive test report with your blood sample so that we can do accurate testing. When a family has a mutation, it's always that same unique mutation that exists in your family. And so that's how we can do targeted testing for everyone in the family based on that relative's positive result. The other thing to consider is that we could have uncertain results. So these are called variants of uncertain significance. And with uncertain results, it means that the current amount of information we have presently has not hit a threshold for the lab to say conclusively if this variant is related to cancer risk, or if it's just part of normal human variation, right? So if you think about it this way, we have 20,000 genes. Some people have blue eyes, I have brown eyes, and even like the difference between brown eyes and my family is different. And that's just due to just normal genetic variation or DNA. So when we're just focused on these hereditary breast cancer genes, there could also be just normal variation in these genes. The majority of these uncertain variants or these inconclusive results, once the lab has gained sufficient information and can reclassify them as either pathogenic, which is disease causing, or benign, over 80 to 90% of uncertain variants, they get downgraded to benign variations. So from my perspective, if I get a variant of uncertain significance, a VUS, I treat it like it's a negative result. I don't fuss or fret about it until the lab tells me otherwise. But sometimes, right, patients can feel a little confused about this whole thing, understandably, and they're sharing this, VUS result with their other family members. And so if someone comes in and has a positive result from a relative, or they say they have a mutation, and frequently we do find out that they're inconclusive results. And so I would not test my patient for that inconclusive result because I can't say with certainty if it's going to contribute to cancer risk for patient or not. But this is where going back to that family history and reviewing the whole pattern of cancers in your family, we can still make tailored cancer screening recommendations, based on that information. All right. So all three of our amazing cancer centers here in the Triad, we have great genetic counselors. This is just a phone number, a running list of all three cancer centers, cancer genetic counselors. If you've had negative genetic testing, have questions about it, definitely speak with your providers about it. You can also just contact the genetic counselors. They can try to help hunt down your original genetic test report and kind of give you an updated risk assessment and see if we need to schedule a formal appointment to revisit your family history and that genetic test report. Thank you for your time.
Thank you so much to Twee and the doctors. And we have a few minutes where I'm going to kind of try to run through the questions that we've had in the Q&A. So I don't know, Dr. Zakon, if you want to join up on camera. And any of the medical panelists, you're welcome to turn on your cameras. I'd like to I'm going to summarize some of the ones that are in the chat or in the Q&A that have been answered that I think are going to apply to lots of people. And then I'd love to do sort of a rapid fire, see if we can answer as many as possible before we have to move on to the next panel. So the first ones that I wanted to look over, a couple of people were asking about vaccine and who's eligible for boosters and that kind of thing. So what we see is, what I'm seeing in the chat is, first of all, active treatment, right? Those people qualify for, to me, it's a little confusing, the difference between a third shot and a booster. Dr. Zakon has educated me previously that a booster is a third shot to boost your immunity the third shot. Some people need a third shot to get their immunity to a good level. And those people are like immune compromised. They were the first round of people allowed to sort of get another shot. A booster is for people who have done a full course of COVID vaccine and maybe your immunity is starting to wane. And so those are the 65 plus who've just been approved for a booster shot. Now, it seems to me like a little technicality. So fair enough if everybody else is as confused as I am. But what was in the chat is, first of all, what counts as active treatment. And so if anyone is currently on chemo, including oral forms of chemotherapy, Ibrance or other brand of pill chemotherapy does count, right? And so those of you who are in that group, yes, should get the third shot or the booster. Sorry.
That would be the booster.
Okay.
Actually, it depends on where they are in their course of things. If they had their primary immunization back in January and February, it's now 6 months later, it's a booster.
Gotcha.
But if they got it like in May, June, and they're on chemotherapy, they can still get it as a third shot. And what's important about all of that is that you don't have to prove it. You just show up and they take your word for it. And when in doubt, ask your physician. Your physician will, we review these rules just every time the rules come out. Letrozole and tamoxifen are not considered immune suppressive drugs.
Gotcha. Okay. So it's really the timing of between shots that makes it a booster versus a third shot.
Sort of.
Okay. So I know.
It's also whether Moderna is included or not. Moderna is included as a third dose, regardless of how long it's been, as long as it's been 4 weeks, if you are immunocompromised. Moderna has not yet been approved as a booster. Probably
Gotcha.
not.
Very hard to keep up with this. Please consult. And we would encourage you to make that call. And our next panel is who you're going to call. So, so then there was someone else asked, like, how far out of treatment, like if you're 5 years out, should that qualify you necessarily for a booster shot? And it was answered in there that that doesn't necessarily qualify you, but as a 5-year out survivor, depending on your age or your other medical conditions, you may qualify.
Or your occupation.
Yes. Okay, then I have sort of a grouping of questions around insurance coverage. So if people know, and it covers, so one of them is, does insurance cover an MRI for silicone implant follow-up, which I think was a pretty good question.
Yeah, I'm not 100% sure, but I have every reason to expect that they would, as long as it's in the context of breast reconstruction as opposed to a cosmetic augmentation. It really, I'm almost certain it will.
Okay. Does medical insurance cover Oncotype Dx?
Yes, that's the short answer. There are some ins and outs about when exactly they will cover it. You can order it off of the initial biopsy, or it can be run off the final surgical specimen. Some insurances, make determination about when exactly we can order it. But generally, as long as you are early stage disease, hormone receptor positive, and HER2 negative, which is the context in which it's approved, it will be covered.
Okay. Does insurance, so someone, I think it was Dr. Cook, mentioned the cancer index test.
That one's a little tougher, only because it's a newer study. So we have been ordering it, I think, fairly frequently here now at Novant for a year or so. I would say most of the time mine get approved. I have had some that I've had to do the next step, which is called a peer-to-peer, when you speak with a provider at the insurance company and try to make your argument. But generally, yes, we can get it through. Sometimes it takes a little work.
Okay. And does that test help to identify if someone is likely to have early or late recurrence? Did you answer that?
So it doesn't look at early recurrence. It is specifically looking at late recurrence. So, when someone is initially diagnosed in the post-operative setting, we generally talk to them about their recurrence risk over the first, upcoming number of years. And then this is a study that's meant to be done at the 5-year mark, looking at late recurrence.
Okay.
And the benefit associated with continuing on endocrine therapy beyond 5 years.
So that was somebody else's question, is how long should a stage 1 survivor take hormone therapy?
So, that's what I was trying to get at in my talk. That's something that has changed over the years. We used to say 5 years for everyone. We then obtained some data a number of years back that there were certain women who would benefit by staying on 10 for 10. We rarely do beyond 10. And what we're trying to do now is tease out who is in that group of women that should or will benefit from years 6 through 10. And that's where this study can help us. So I can't really answer just stage 1, 5 versus 10, because there's a lot of ins and outs. But the test I mentioned is part of the decision-making process.
Okay,
awesome. Like tolerance, bone health, weighing all the ins and outs of ongoing endocrine therapy.
Can someone, back to the COVID vaccine, can they get the COVID vaccine while on radiation therapy?
Absolutely, yes.
Okay, easy.
Already get it and get the flu shot right along with it.
Got it. For mammogram, someone asked, when do people start having regular mammograms again after treatment?
So that depends on, some surgeons will recommend you having a mammogram 6 months after your initial surgery and then doing annually. We like to keep you at a diagnostic exam for the first 7 years, because we'll do an extra picture at your lumpectomy site. And after 7 years, you can go back to routine screening. On the other hand, if you've had a mastectomy, you can come back the next year just for a regular screening mammogram.
Thanks. One other mammogram question. You're fine with people in the background. Don't worry about it. We're all used to this now. The next mammogram question is someone, so I think a lot of people are thinking about their family members. So this is a person who has an adult daughter. So the mother has cancer and has an adult daughter. Paternal aunt also has cancer. When should that adult daughter start mammograms?
So the recommendations right now are pretty straightforward if you're talking about one first degree relative. So it's mom, a sister, or daughter. It's usually 10 years before that first degree relative was diagnosed. It gets a little more complicated, and you can talk to your genetic counselor about further recommendations if the family history is a little more extensive.
Okay, so that would be Twee and her friends. If you, probably depending on when this person was diagnosed and a larger picture, to consult with the genetic counselor about whether you need testing or if you've already had it, if you need updated testing.
Yeah, because once you start getting more family members involved, it might qualify you to have a screening test like an MRI, which we can alternate with mammograms, so you can get tested multiple points in the year.
And that's part of the risk assessment that we provide for patients in our breast center, is that, you know, we often have women coming in who have breast symptoms and a family history of breast cancer. And so we review the family history of breast cancer, and we have several risk models that we can use that sort of incorporates her own personal personal risk factors as well as the family history. And so from there, we can that's how we can really tailor, you know, when women need to start screening mammograms, if she would qualify for other, you know, extra screening modalities such as a breast MRI.
Great, thank you. One other question: can someone move a transplant from under to over muscle?
An implant, and yes, absolutely, we can do that.
So if someone had it put under their muscle and they, how long do they wait? Or
If they've had it under their muscle, I mean, I would say just about 3 months. Anytime after 3 months, if they're having pain or animation deformity they don't like, we can go in and switch the pocket with a single operation most times.
And who would they talk to? Our next panel is who you're going to call, but I feel like that is a doctor question. Who, if someone had that and they would like to explore if they could swap it, who do they actually talk to?
The plastic and reconstructive surgery folks.
Okay.
Any of us at either medical center will be able to address that. Most likely we'd be able to go right through an existing scar, so no new scar in most cases. And it's an operation actually that's probably happening not infrequently right now with the new trend towards on top of the muscle.
Okay. For women with reconstructive surgery on both breasts with silicone implants, how do they do their mammogram or their monitoring? Or do they do mammogram, MRI? How does that work?
So we still recommend that you have a screening mammogram every year. The way they do that is they'll do, instead of 4 pictures of the breast, they'll typically do 8 pictures of the breast. So one picture will have the implant in place, and the next one they'll displace that implant to get a better tissue or view of the tissue underneath.
Okay. And someone is asking about hair loss. So obviously a lot of people lose their hair during chemo, but this person is 10 years out, still sort of thinning hair challenges. Her medical team recommended Rogaine, wondering if that is a safe option for people who feel like their hair isn't growing back as full as they would like. No one wants to answer that one.
Can you repeat that? I'm sorry. I was messaging someone else in the chat and I missed the question. I apologize.
No problem. It is about hair loss. So someone is 10 years out, hair has grown back, but it's not as full as they would like. And their doctor has said, or someone recommended Rogaine. And so she's wondering, is that a safe option for people who aren't really satisfied with the fullness of their hair?
Yeah, it's a safe option. I mean, hair thinning is unfortunately a common issue we see amongst our patients, not only related to chemotherapy, but also women on anti-estrogen therapy. You know, the analogy I draw for a lot of my patients is if you talk to a lot of women who've just gone through natural menopause, a lot of them will describe hair thinning. So some of it is simply an estrogen loss effect. Rogaine is safe. I don't think for most women it's a home run. I feel like most of my patients who've tried it have not noticed a significant difference. But I certainly don't have a problem with them trying it. You know, I've had patients talk to their dermatologists or even their hairdressers about other options for thickening hair growth. But unfortunately, it is a side effect of losing estrogen.
Gotcha. Well, Lindy just sent me a message and said it is time for us to move on. She is the driver. So we always appreciate all of your expertise. I'm sorry for people whose questions didn't get answered, but we are running out of time. So if it is, I would encourage everyone to contact their medical team. If they do have questions, our next panel is actually who you're going to call. So we will talk with some of the other, staff who are available to our survivors to find out who they should call when they have various questions. So thank you, doctors. I know everyone is at home clapping for you. We appreciate you coming and joining us.
Thanks for having us.
Okie dokie. So we are going to transition over to the who you're going to call expert panel. And if you have questions for this panel, put them in the chat just like you did before. All of your questions are really, really good. And I think very helpful for other people to hear. So if our who you going to call can turn on, we don't have slides for this one. So it's going to be a conversation. And what we will do, let's see, get me my right notes here. Okay, so this panel was really inspired by a lot of our clients who kind of wonder, when something's not quite right, who am I supposed to call? I have this whole team of people, but I don't know who the right person is to call, right? And you've got your oncologist, your primary care physician, you've got cancer services, you've got Google, but we would suggest you don't call Dr. Google. Because it's going to scare you to death and likely it's full of the wrong information, send you down some kind of rabbit hole that you do not need to worry about. While there's reputable sources out there on the internet, it's very difficult to tell the difference. So I am also one that really recommends that you find your trusted medical team and figure out who to ask so that you don't get stuck going down those rabbit holes. So we hope that our panel today is going to answer those questions. We have with us Kathy Bowman, who's a breast nurse navigator at Novant, Liz Outlaw, who's a breast nurse navigator at Atrium, Wake Forest Baptist, and then we have two of our patient advocates at Cancer Services. So we have a whole team of advocates, but we've got Felicia Dobson, who is our liaison with Novant Cancer Center, and Tiffany Morrison Brooks, who is our liaison with Atrium, Wake Forest Baptist. And before COVID, they were physically located at those cancer centers, but are now working mostly from home. But we would like to start first with Liz, who is going to talk with us a little bit about what the role of a navigator is. So both Novant and Baptist, as well as several other cancer centers, do have breast navigators on site. And so Liz, can you give us a little bit of an overview around what your role is?
Sure, thanks. So the breast cancer nurse navigators, our role on your care team is essentially to be your person, your point person from the moment you're diagnosed until you get out to survivorship clinic. We're your person to call when you don't know who else to call. We can connect you with the resources you need. We can kind of filter out your questions, answer what we can answer, and then escalate when we need to the medical team or the surgical team. We work really closely with our patient advocates at Cancer Services. So if it's something that Tiffany can help with and has, that skill set, then I can take it to her and we work together to help our patients. But essentially our role is to be the point of contact for any of our breast cancer patients who, with any question along the way. It can be overwhelming. Like you said, you have all these people on your team and you get all these different phone numbers and you meet all these people, especially in the beginning. What I try to emphasize with our patients is if you don't know who to call, you call me. And then I figure out where it needs to go. If it's not for me, then I'll get you where you need to be. Otherwise, I'll help you. But we are here to make it as easy as possible on our patients on this journey that they're beginning. One other thing that I know Kathy and I talked about earlier this week, we're not just here for the beginning. We're here for the long haul. So from beginning to survivorship, if you're 10 years out and you don't have a navigator anymore and you have a question, you can still reach out to any of the navigators at Atrium or Novant, and we'd be more than happy to help you with whatever we can help you with. So we don't want you to feel like you're alone just because you finished your treatment. We're still here for you.
Awesome comment from a participant. Breast Navigators rock.
Oh, thanks.
I know. So, Felicia, if you will help us understand about the role of the patient advocate, where does that fit in?
So hello, everyone. My name is Felicia Dobson. I'm a board certified patient advocate with Cancer Services, and I've been a part of the agency for 11 years, where our overall mission is to enhance life, health, and survivorship. So it's bad enough when you're healthy, but when you're exhausted and sick with a condition or disease, navigating the healthcare system can feel nearly impossible. So I'm very happy to give you an introduction as to how patient advocacy can benefit you all. Patient advocates are available from the point of diagnosis throughout survivorship. Some members of the interdisciplinary team that we work closely with include, but is not limited to, the physician team, social workers, case managers, nurse navigators, financial counselors, and we are able to make referrals to a host of helpful in-house, which is, the hospital and community resources. Our ultimate role is to make sure patients' needs are met. We do that by making sure the patient's rights are met. We solve conflicts, crises, working along with healthcare professionals and family members. We help patients communicate with their healthcare providers so they can get the information they need in order to make decisions about their healthcare. We also look at current or potential barriers, such as lack of reliable transportation to appointments or treatment, what physical barriers have presented, and there may be need for equipment or supplies, in order to maintain that quality of life. We look at lack of financial resources, and we look at the lack of education and awareness, in general. So barriers are kind of our specialty. Just like most things in life, some things can happen, we expect to happen, and then some things are just abrupt. So along with treatment, job status can change, insurance can change, your support system can change. And there are times when a patient who normally handles everything just needs some direction and help organizing their life. So we patient advocates, we just look at everything as everyone has individualized needs. So the patient advocate's role becomes very flexible and varying as necessary. So one takeaway from my spiel and the benefit of working with patient advocates is that you don't have to exactly know what to call and say, just call. So we'll speak with you, and in that, we will be able to uncover what your needs are, offer the supports, the information, the referral, and the assistance. So thank you.
Thank you. So what we want to kind of do now is think about some scenarios that people might be facing. And one of those is the cost of treatment, which can be, kind of a shocker. Once you get, you figure out your plan, and then all of a sudden, let's say you are prescribed a new medicine, you're thinking, here we go, we're going to figure out how this is going to, get me moving in the right direction. You go to the pharmacy, you find out how much it is, it's really expensive, and you are feeling like there is no way I can afford this. So Tiffany, we wanted you to kind of take this one on. Who should someone call if they go to the pharmacy and they're like, I cannot afford this medicine?
Well, good morning. I'm Tiffany Morrison Brooks, patient advocate for Cancer Services, and I cover the satellite office for us at Atrium Health Wake Forest Baptist. And I want to echo what Liz and Felicia said, and I'm certain it's what Kathy's going to say, because we really always stay on one accord across the whole work, the work of navigating and advocating. But we want you just to call us and ask us what you need, and we're going to help you get your copay assistance. Some people have Medicaid, and that means that we're just going to go ahead and help you take care of that. It's an easier copay. But if you have a really high copay, we will guide you from there, and you may be able to get a grant through a copay assistance or through other programs that can help you. So never get overwhelmed when you hear the price. The first thing you do is you call us, call me, or call Felicia, call Liz or Kathy, just call one of us before you panic. And then one of us will guide you to the other, because as Liz said, she'll get you to me and I'll get you to her, but we really do work together. And I'm sure this is the way Felicia and her team at Novant Health work as well. So just give us a call. But the first step one, do not let it get you. Don't let this one get you. We can handle this. That we've seen it before, and most of the time we can find you some way to relieve that financial overwhelm. So you can call our main office, and our main office number is 336-760-9983. And you can ask for any patient advocate, or if you want to ask for either of us specifically, you may.
Great. So that's the Cancer Services number, and we are available 9 to 4 basically every day. And we can get you over to Tiffany or Felicia. And a lot of times the pharmacies will contact the patient advocates directly, right?
Right,
They will. If
will.
it's the pharmacy in the cancer center.
They will, and we really just work in tandem with several different systems. So we branch out into several different perspectives and branches of the work. So we might get a call from pharmacy, other advocates, from navigators, from patients and families. But the other thing I really want to make sure I stress to you is, because of the changes we've had through COVID, you may get calls from numbers you don't recognize, and just know that our numbers are scrambled when we call from out of the Wake Forest Baptist or Atrium Health system. The number is going to scramble, so you may not know, you will not know who it is. I would say go ahead and answer. If it's not the right person and it's about your car's extended warranty, hang up. First, answer, because we may have something for you. We may be trying to. The likelihood is that we're trying to get to you. And so you may even see a blocked number. Again, just check, because we're working on getting those barriers down so that you'll recognize that it's us. But go ahead and answer, because we might be trying to find you so we can relieve you.
So yeah, the patient advocate team can assist with all types of financial resources. We don't, they don't guarantee that they will find something, but if you feel like the costs of things are overwhelming, I would encourage you to call Cancer Services, just have a conversation like Felicia mentioned with an advocate, and the advocates know all the resources that are available, so that basically you can maximize your money and keep on top of your treatments. Okay, so some of the other things that people often have questions about, and I have a couple of friends in treatment now, and this is something that especially early on in treatment or even in the middle of treatment, having side effects from their treatments, feeling kind of miserable, but also questioning, is this normal? Is this just how I should be feeling? Or should I call somebody about that? So Kathy, can you help us out on who somebody should call when or if they're experiencing that situation?
Absolutely. And I'm so glad to be with you guys today. It's such an honor to do what we do. I know Liz and I both agree on that. It's an honor to go beside patients and their families and do what we do. So like Liz says, she tells her patients, we tell our patients the same thing. If you don't know who to call, just call us. And we'll be definitely glad to route that call where it needs to go. If a patient calls one of the navigators here, we assess what's going on. We ask for more information, and that may help us answer the question that they have. A lot of times patients just need clarification about treatment. They've had so much information come at them at one time. Sometimes it's a surgical question. Sometimes it is a question about side effects, and they just want to know, is this normal? Is this supposed to happen? And we are able to kind of talk through it with them and can answer that question. Sometimes if it's an urgent need, we encourage them to call the surgeon or the medical oncologist. Sometimes we help facilitate that. We may take down the information and also share that information with their physician and their nurse as well. But we encourage them to reach out to that specialist.
Okay, so in this scenario, yes, they should call somebody, right? So
Mhm,
I
yes.
think generally everyone agrees you should not be absolutely miserable.
Right.
So in that case, let's say it's a Friday night at 9 o'clock. You know, someone had their treatment like Thursday or Friday and they thought they were feeling fine. And then boom, of course, after 5 o'clock on Friday, they start feeling awful. Who do you call after hours for your medical questions?
So we have an emergency, we call it, I guess, the after hours weekend number. That's the 336-277-8800. I believe Lindy put that up. We make sure, especially when we visit them in chemo, or we make a phone call on Friday and touch base, usually with the folks that have had surgery that week, our folks in chemo. When we're seeing them for the first time, first treatment, we always make sure they have that number.
And Liz mentioned to us earlier this week, and Lindy put it in the chat, Wake Forest has a 24-hour number as well. And Wake Forest has a surgery 24-hour number. So Liz, when would you call the surgery 24-hour versus the regular 24-hour?
So at Wake, we have a medical oncology 24-hour number. And that is for, you know, I'm having chemo, I'm having chemo side effects, anything that's not surgically related. If you just had your surgery and you're home on Friday night and all of a sudden you're having increasing pain, or your drains are getting rapidly filled up, or whatever your surgical issue is, then you would call the surgical line.
Gotcha. And we will, those are in the chat, but I'm also going to take a note that we send those numbers out with our follow-up email today. To make sure that you all know who to call. Now, what if somebody, so those are for kind of in treatment people, they hopefully have already met one or both of you or the colleagues that you all have to cover. If somebody's out of treatment, but they are starting to feel like, I have this weird thing going on, I'm not sure if is it my cancer's back, or is it related to my treatment? Like, do I call my PCP? Do I call medical oncology? What would you tell that person?
Please call us. We'll talk through it. And I would rather, and a lot of times I know that we do that here, we'll message the medical oncologist, and they're great about getting back to us regarding a question that a patient may have, you know, whether it's a recent patient or somebody who's 5 years out. They'll get back to us and help us figure that out.
Okay, so that would be, even if you are a couple of years out and like say the hair loss question, that person's like 5 or 10 years out and their hair's not, and they just feel like I need to ask somebody. They could call the nurse navigator and you all would tell them, oh, that's a question for your PCP, or, oh, that's a question for, you know, who else, right?
Sure.
Yeah.
And
I think, sorry.
Go ahead, Liz.
I was just going to say, you know, I think Kathy and I and all of our colleagues are kind of all on the same page with this, that we don't want you to be at home worrying about something and not reaching out because you don't know who to call. So just call us. Even if you don't think it's us, you can still call us and we will get you to the right place to get your questions answered or your fears allayed or whatever needs to happen. But I know we all feel so strongly that we don't want you sitting at home worrying about things. You know, that's our job. Our job is to take the worry from you and get you plugged in with who you need to see so that you feel better about whatever it is that's going on. So just call us anytime, no matter where you are in the journey.
Yeah.
And I think the advocates are the same way, especially for survivorship. Sometimes I think patients feel like, well, I'm no longer going to the cancer center regularly, and I don't know if I should bother them, or I can't find my phone numbers. Our advocates are always available to basically reassure you that, yes, those are people you should continue to consult. What about, someone is asking, what is a case manager? So do the treatment centers use case managers? And if so, how are they involved? I think sometimes people will have case managers with their insurance companies. I don't know if someone can speak to that as well.
We have case managers on the floor here at that are the case manager, and they make sure before the patient's discharged that certain things and needs are met. We have a social worker here that I would guess would do along the same lines. We use like Felicia, and I know Felicia works with DeCarlos, and a resource specialist, Stacy, that we have here, that I would consider that role like in our outpatient cancer center.
And it's really a good working relationship. When I mentioned case managers, I was specifically speaking about the case managers on the floor. So I don't think a lot of people realize that, when I stated we work with patients from point of diagnosis, throughout their journey, it's literally the point of diagnosis. So there's some patients that are on the floor, they have case management, and this is just, a lot of new information being thrown at them. And the case managers can contact cancer services. We can start to get those supplies in the home while your insurance is, working out what it's going to cover. But, our supplies are at no cost. So someone can pick those up. It's just a great transition into, what's next, the treatments, and speaking with the doctor. So working with case management up front is great for cancer services because we're able to foresee the medications, those just discharge medications, which, oncology medications can be a whole different ballpark when it comes to, what they cost. And DeCarlos is a social worker at the cancer center that I work closely with. And the working relationship there is that there are some things that I can take care of as a patient advocate, but there's certainly things that, the social worker needs to address. And that's just the beauty of working with a navigator, a patient advocate, or the social worker, because you can kind of talk to one of us as a one-stop shop and just know you don't have to figure out each and every individual that's going to, take care of those responsibilities. So again, like Liz said, we just want to take that off your plate.
Very much a team effort.
Yes.
So then there's also a good question. Which provider coordinates transferring a patient to survivorship care? And I don't know if each center does it differently, but can someone speak to, at least one person from Novant and one person from Baptist, can you speak to how you transition breast cancer patients into survivorship care from active treatment?
Sure. So it's funny, we actually just had a meeting about this today, this week, about transitioning to survivorship at Atrium Wake. We have breast cancer survivorship clinics that are run by the APPs that work directly with the medical oncologist and the surgical oncologist. So they have, oh, sorry, my cat.
Kids and cats, yay!
They have their own individual survivorship clinics. So if you are, and they're working on a kind of a streamlined process for this, but in general, at 5 years, people consider that survivorship time. If you are still taking, say, letrozole or tamoxifen or some sort of oral medication, you will most likely transition to the breast medical oncology survivorship clinic. Our surgical survivorship clinic, those patients transition about a year or two after they've had their surgery, and they just continue there for their screening mammograms or diagnostic mammograms and annual visits with the APP there. So that's something, it's individually tailored for each patient right now because, everybody has different circumstances, but your medical oncologist and surgical oncologist kind of decide when you graduate to survivorship.
Okay. And Kathy, is it similar at Novant or?
The medical oncologist here usually makes that transition. The patients do follow up with their surgeon, usually at a year, and sometimes a little more often, but usually it's the medical oncologist that gets them into that survivorship.
Good. And I think I would also differentiate a little bit between like your clinical follow-up or survivorship care versus some of the other like emotional aspects of survivorship and some of the other needs that might not necessarily be taken care of by your medical facility. So at Cancer Services, we offer a transitions program, which helps to cover things like what are the exercise recommendations? What are the nutrition recommendations? How do you emotionally cope with what just happened to you? And also we do have someone who speaks to the medical management. So in the chat, one of the participants mentioned the counselor at Novant was helpful to them. And Baptist also has a cancer patient support program with counselors available. So I think also recognizing that for survivorship, there's a lot of places. And so we would encourage you to think about, as you're approaching the end of active treatment, how can advocates, navigators, and other staff support you in that? Because you kind of need to create a plan of action. And we can all help you to figure out what those next steps are. And it looks a little different for everybody. Some people like to be, informed in group settings, and some people like to figure it out more on their own. So I think all of us are willing to help assist you and coach you along that process. As I wrap up this panel, I will say some people also ask, if you don't know, I'm trained as an oncology dietitian. And some people also want to know, well, when should I call my treatment center dietitian versus calling me over at Cancer Services? So I'll also tell you that generally the dietitians and I work pretty well together, just like the advocates and the navigators do. For the most part, if you have treatment related nutrition issues, mouth sores, unable to eat, nausea, those kinds of things, then your treatment center dietitian is the one to call. They have access to your medical team. They work with your navigators. They can help get medications adjusted quickly or figure out what might be going on. And then if you have questions more about survivorship type nutrition, or how can I, stay healthy during or after treatment, or is this good or bad? Someone asked earlier the flax question. Yes, you can consume flaxseed in its ground up form. That's perfectly healthy, even if you are taking tamoxifen. Those types of questions are the ones that typically are sent to me. So the dietitians at the cancer centers, there's 2 at Novant that are outpatient dietitians. There's 2 at Atrium that are outpatient dietitians. I got a message from one of them yesterday. So I think it's just a really collaborative environment. And we're so fortunate to be here in this setting where people are just wanting to help. And that's been my experience. I know for everybody else here on the panel, we're not, we're just here to help the patient navigate however is necessary. So I want to thank all of our panelists here for being on, for sharing your expertise, for being available to people. I know it's a big benefit.
Thank you.
Thank you.
Okay. Thank you, Tiffany, Felicia, Liz, and Kathy. So what we're going to transition to next is, of course, what everyone loves, and you may or may not know about me, is not my favorite, but we have streamlined the process this year for our prize drawings. So our door prizes this year, I don't know how many were on last year, but this year's door prizes are going to be, aside from our pre-game that we need to give prizes to, which are real life prizes. For the most part, these are, gift cards. Okay, so anybody who wins a door prize today, we will just mail you the gift card. You don't even have to come by the office. Isn't that so great? And we will go ahead and also tell you for the beginning prize. What are we calling that? The scavenger hunt? Smartphone scavenger hunt?
Right.
That will tell you your prize. So Lindy, what do you want to do first?
Let's do the phone prizes first.
Okay.
It looks like Christine was one of the winners with the most points, which was 200.
Wow.
The game had a maximum of 250. So it's kind of hard. You can't really reach 250 because you can't have 0 unread messages and 800 unread messages at the same time.
2 inboxes. I could do it.
Well, you probably could. But anyway, Christine, there's a basket waiting for you at the office. You can come pick up next week. You can call the office and let us know when you're coming. And also Angie had
Congratulations,
0
Christine.
points because she does not have a smartphone. So Angie, there is also a basket for you and you can pick that up next week as well. So before I start with the gift cards, I do want to start with kind of a traditional door prize. Janice Snyder, who is a wonderful friend of Cancer Services, and she has handmade over 100 quilts for us, has made a quilt for this event for a number of years, and she has one that she's made now. Julie's holding it up. It's absolutely gorgeous. It has lots of beautiful butterflies on it, lots of bright pink. So I'm going to draw the winner for it first. That way everybody's name is in the pot. And if you win this, you do need to come by the office next week and pick it up.
Sorry, can't cram it in an envelope.
Right, exactly. Okay, so the winner of the quilt, and I have a good old trusty bucket of names here.
Sorry, you know what that looked like a little, I have a toddler and a potty.
It does look like it's, I promise I got it out of the kitchen, not the bathroom. Okay, and the winner of that is Esther Spa. Congratulations, Esther.
Esther was the first registrant. She actually registered before we ever announced, like somehow she found that registration was open in the like one day between when we opened it and then told everyone it was open. She was the first one registered.
Yep. Awesome. Okay, so now the gift cards, and as Julie mentioned, we will just put these in the mail to you so you don't have to come pick them up. The first prize is a $10 Starbucks card, and it goes to Adele Palmer. If for some reason you would rather come by the office and pick this up instead of us mailing it to you, if you'll just put that in the chat box, that would be great. Then we'll know. All right. Next one is a $15 Target gift card. And that is Abby Monclova. Congratulations, Abby. And I'm glad to have you here with us again this year. Next is a $15 gift card to Panera. And it goes to Rochelle Vincent. Rochelle Vincent. Next is a $15 gift card to Dunkin' Donuts, and it was donated by one of our survivors who's on the call with us today, Rosalind Lentz, and we really appreciate her generosity for donating that. And the winner of that is Annie Duck. Next is a $10 Starbucks gift card. And that is going to Lisa Carpenter. Congratulations, Lisa. Next is a $15 Target gift card. And it is going to Loretta Hughes. The only bad part about this is that we don't get to see your reactions when we call your name. So
some people are putting it in the chat.
Well, that's great. But I do miss that. I do miss the whole woo and everybody at your table cheering for you and all that. So maybe next year.
Maybe. Has to be next year. I'm sorry.
Please.
Has to be next year. I do like the virtual piece. Oh, yay. Rochelle is streamed.
Yay. She's screaming. Yay. All right. The next one is a $25 gift certificate to T Lightful. And this is donated by Martha Eisenberg, who is also a survivor. And she has had T Lightful in our boutique for many years. And so she donated the $25 gift card, and that is going to Kathleen Maxwell.
I should have one of those play things where you clap like the
whatever
the little
it's called. Emojis. Yeah.
Woo.
Okay, next up is a $5 gift card to Starbucks, and that is going to Kathy Goodwin. I know I had some of you, I was holding you on the line with that because there's several Kathys on the call. Kathy Goodwin is the winner of that one. Next is a $10 gift card to Starbucks, and it's Rosalind Lentz. So she's the one that donated the Dunkin' Donuts gift card. So Rosalind, you'll have a Starbucks gift card coming your way. Next is a $15 gift card to Target. And that's Martha Eisenberg. So apparently it's really good luck if you donate a door prize.
Yep, good karma. I'm also going to put in the chat, if you do want to donate to Cancer Services to support our programs, we have a way you can text to donate. No guarantees that like if you donate, you get door prize winnings. I think that's just the universe coming around here, but
it is. Okay, next is a $10 Starbucks gift card, and that is going to Stephanie Henderson.
Both Lindy and I are taking notes so we can compare and make sure we got it right.
Right. The next is a $25 gift card to Bath and Body Works, and it was donated by Jennifer Wiseman, who is celebrating her 10th year of survivorship this year, and the winner of that is Melody. And Melody, if you put your last name in the chat box, that would be great. If not, we'll be able to find you by your email address. The next one is a $75 Amazon gift card. And it was donated by Dignity Products, who is, one of our big partners and provides lots of wonderful things for you all. They also have just relocated, and there was a card in your goodie bag that told their new address. So you will have that, and this Amazon gift card is going to Christy. And Christy, if you could give us your last name too, that would be awesome.
That's awesome.
And then next is a $50 gift card to Midtown Cafe and Dessertery. And it was donated by Elegant Profile, another wonderful partner of ours that provides all kinds of things for your prosthetics, mastectomy bras, all kinds of things like that. So they've been a wonderful partner as well. And this is a $50 gift card to Midtown Cafe and Dessertery, and it is going to Stephanie Brewer.
Yay, Stephanie.
Yay. And our last door prize is a $100 gift card for Google Play, and it was donated by Cheryl Thorpe, who is one of our wonderful volunteers, and we are always so thankful for everything she does to help us. So that, whoops, I just dropped a name. Okay, so that is going to Michelle Vanoy. Congratulations, Michelle.
Hooray.
All right. So that's the gift cards. I hope you all have enjoyed today so much. Congratulations to our door prize winners. Thanks again so much to our wonderful doctors and our expert panelists for sharing your time and energy with us today. We have done pretty good on staying on time, but everybody likes to stay a few extra minutes for a door prize. So you will get an email from us that will have a link to an evaluation, and we hope that you will take a few minutes to fill that out so that we know what you enjoyed, what you liked, what we can do to make this better next year. You don't have to have it in person because we know that we want to do that to make it better next year. But I hope you've had a great time. Hope you have learned a lot. And Julie, Will you
Yeah.
send us off?
I will. So I want to make 2 announcements and then we'll officially send you off. So the first is that Krispy Kreme is doing a breast cancer awareness event. So if that's your thing, you can get 1 free glazed donut and 1 free cup of coffee. And that is Friday, October 15th. So 2 weeks from yesterday, Stratford Road location between 8 and noon. So if that's your thing, I also put in the chat that if you would like to financially support the programs at Cancer Services, there's a PRT 2021 code that you can text to 44321. We'll also put that in the follow-up email, but there's lots of ways to support us. Like some people have donated door prizes, but even just thinking about items that you have, things like wigs that you're done with, or any other type of items that maybe you purchased but didn't use. We have so many things that breast cancer patients request from us that come by and use for all free of charge. So if you want to help support by giving your unused or gently used items, we can definitely help to make sure those go to newly diagnosed patients who need it. So lots of ways to be part of our, sorry, don't look, it's making you dizzy. I'm trying to get to the last slide. Let me stop this and get there. Lots of ways to support us. Now we are going to send you off for the day. As Lindy said, almost exactly on time, which is sort of a miracle if you ask me. And this is how we like to end PRT every year as we send you off. And this is on the back of your booklets. If you need access to any of the program materials from today, you can find that on pinkribbontalks.org. I will also send a link to this recording afterwards. So if you missed anything, you can watch it again. And we will hope to see you in person next year. And we'll send you off for the day so that you have an awesome day as you kick off Breast Cancer Awareness Month. So you can join in with me at home if you have it with you. Dear great heroic lady, now go forward with bells on to the grand ball of life and fill your new dance cards with twirls and whirls of wonder. Your heart is deserving and your soul is ready. We hope you all have an awesome day and a wonderful month, and we look forward to seeing you again in another event this month. Thanks so much. Have a great day.
Thank you.
Yeah, I know. We should do the round of applause. Any committee members, if you're on, you can show your faces and wave. Hooray, and our doctors. All right, so I'm going to give a few minutes and then I'm just going to end the meeting. It's such an abrupt ending. I hate to do it, but I don't know any other way to do it. Okay, so if you're on and you unmute, let's do this. Let me stop sharing so we can all, whoever's on, unmute, show your face. We're all together going to say bye, and then I'm going to say 3, 2, 1, and then I'm going to hit the button, okay? Everyone ready? Okay. Bye.
Bye, everybody.
Bye.